Good afternoon, Honorable Chair, respected teachers, and my dear colleagues. Welcome to this session. I am Dr. Debnath, Medical Officer of NICBD Unit 18, under the Professor of Nur Alam Sir. This is a great pleasure for me. I get a chance to present this case in such a big dais, and I am grateful to Associate Professor Nur Alam Sir for giving me the opportunity. And today's my case is bee bite, might be a big bite. My patient, 50 years old, a businessman, smoker, was stung by bee while watching collection of honey from honeycomb 3 days back. He developed central chest pain, sweating, rash, along with generalized body ache. With this complaint, he attended a local physician and treated with hydrocortisone and antihistamine. On that time, an ECG was done which showed abnormality and referred to a tertiary care hospital. There he was diagnosed a case of myocardial infarction and treated conservatively and referred to NICBD for further management. And he had no significant past history of allergy and chest pain. On examination, there was ecchymosis present over face, arm and neck, and conjunctiva is congested. His vitals are normal, and the other systemic examination reveals no abnormality. This is the graphic. This is the picture of this patient who is just taken with permission. There is conjunctiva is congested. There is ecchymosis present over face, neck, arm. This is the initial ECG of the patient is missing due to he lost his ECG. So ECG is taken one day after the admission of patient, and this show heart rate 80 beat per minute regular. There is ST elevation in 2-3 AVF and QF in 2-3 AVF, and there is also ST depression in 1 in AVL. And this is the another ECG of this patient who was taken 2 days after his admission. This shows heart rate 90 beat per minute regular. There is QF in 2-3 AVF and T inversion in 2-3 AVF V4 to V6. And baseline distribution normal except rest troponin I. This is the echocardiogram which show hypokinesia of the distal inferior wall in apical 2-chamber view. And patient is treated in hospital with antiplatelets, statin, nitrate, antihistamine, and after that we plan for coronary angiogram. Coronary angiogram done through right radial access, and this is the RO caudal view showing significant lesion in left circumflex artery, which is about 60 to 70% proximal to OM1 and OM2. And this is the RO epicranial view showing 30 to 40% lesion in left anterior descending artery. This is the spider view which showing the significant lesion in left circumflex artery proximal to OM1 and OM2. And this is the areocranial view which is showing 30 to 40% stenosis in the mid LAD. And now the right system. And this is the RO view showing 70 to 80% lesion in the distal RCA with normal PDA and PLV. And this is the AP view showing same lesion in the RCA, and the aleocranial view showing the same lesion in the RCA. This is the angiographic finding. So history of stung bite followed by myocardial infarction and angiographic finding. My diagnosis is Kounis syndrome type 2. So I want to give some information about the Kounis syndrome. And Kounis syndrome is the occurrence of acute coronary syndrome in the setting of allergic or anaphylactic reaction. And it is first reported in 1950 in a 49-year-old man. Kounis and Jabras first described the pathophysiology of Kounis syndrome. And it is not a rare disease, and so incidence 7.9 to 9.6 per 1 lakh inhabitants in a year in a case report of. And this is the pathophysiology, mast cell activation and degranulation in the center of pathophysiology of the Kounis syndrome. There are several triggers for Kounis syndrome, such as drugs, which is the main trigger. It includes antibiotic, antineoplastic, analgesic, which include NSAID and morphine. And there are sub-environmental exposure, such as bee insect bite, bee sting, and there also have some food. After triggering factor, there is also release of, there is activation and degranulation of mast cell, and there is release of mediators such as histamine-related activating factor, arachidonic acid metabolite, cytosine, and tryptase. This causes local and systemic effect. systemic hepatitis, anaphylaxis, and local affecting to myocardium and coronary artery, which include vasoconstriction, vasospasm, plaque rupture, plaque erosion, activation of coagulation cascade, and followed by thrombus formation. And there are 3 types of Kounis syndrome. Type 1 is allergic coronary vasoconstriction, which occur in a normal coronary artery in a patient with patient may have previously microvascular disease or endothelial dysfunction. In type 2, there is acute coronary thrombosis in patient with pre-existing coronary artery disease, and this occur in my case. In type 3, occur in a patient with previously drug-eluting stent, and this drug causes histamine activation, release, and thrombus formation, and aspiration of thrombus and staining reveal presence of eosinophil and mast cell. So diagnosis of Kounis syndrome, there is difficulty in diagnosis as there is diverse clinical manifestation, and clinician should have a mind that Kounis syndrome may be present in all cases of allergic reaction. And this is the management. Emergency management should be done in case of Kounis syndrome, and there is as early management there is improved prognosis, and there is simultaneous management of allergic reaction and coronary syndrome should be done. And in the allergic, we should remove the patient from trigger. There is oxygen inhalation and IV fluid if needed, and we should give antihistamine and IV steroid. For acute coronary syndrome, we should give antiplatelets, statin, and we also give nitroglycerin and calcium channel blocker. We should avoid epinephrine and beta blocker as this may more aggravate the vasoconstriction and vasospasm. And we should also avoid morphine as they activate the mast cell and degranulation of mast cell which also aggravate the situation. So in conclusion, Kounis syndrome is not uncommon but is a frequently unrecognized or undiagnosed. Early diagnosis is a paramount importance because of its high mortality due to cardiac arrest or sudden death. Emergency clinician should always consider Kounis syndrome when dealing with any kind of degree of allergic reaction. Management is challenging as there is no guideline. Avoid epinephrine, beta blocker or morphine during management as this may worsen the situation. Thank you for your patience hearing.